tablets, what's new in obesity pharmacotherapy. So welcome.
Thank you very much again for inviting me today, and I know that I'm keeping you from lunch, so I will try my very best to deliver this as quickly as I possibly can. So I'm going to skip this, and I think we've seen this slide many times today, so we know that we can achieve improvements in blood pressure and hypoglycemia even with small amounts of weight loss, 2 to 5%, but we really need to sort of move to over 15%, 10 to 15% to improve several complications, including reducing cardiovascular risk, type 2 remission, remission of type 2 diabetes, and so on and so forth. And so far, until recently, we only had bariatric surgeries to get us there. But now we've got pharmacotherapy. This is just to remind us about the history of pharmacotherapy, which has not been a pretty history, really. Just to remind you that lots of drugs that were approved for weight loss have been removed from the market. In the 90s, we had all the amphetamine-based drugs, which caused cardiac death and fibrosis. We then had sibutramine, which caused increased cardiovascular risk, which was discontinued in 2011. Rimonabant in 2009 worked on cannabinoid receptors. More recently in the States, lorcaserin in 2020. So really not a good history, okay? But now we do have effective medication, and I think it's fair to say that we have bridged the gap between lifestyle and bariatric surgery. These are the currently NICE approved medications that we have in the UK, so orlistat, you're all familiar with that, I'm not going to cover that. The Ribupatide 3 milligrams of Saxenda, which is really not available, and I think pretty much nobody uses it anymore unless anybody else does in the audience. We do have semaglutide, and soon we're just waiting for NICE to tell us about when tirzepatide is going to land itself, and I think Adrian showed a sort of 12-year rolling plan earlier on. But anyway, a little bit about that later. But anyway, I think there's no, there has been a stampede. Everybody's sort of switching from lifestyle, to pharmacotherapy, and why is that? Well, the reason is because it works, and we said that sort of the story, I guess, started with semaglutide, 2.4 milligram once a week from the Step 1 trial. This is the result of the Step 5 trials, which essentially is after 2 years, and you can see very nicely that you get about 15% weight loss, which is maintained if you keep taking the medication. This was soon followed by the SURMOUNT-1 trial, which looked at 5 doses of tirzepatide, 5, 10, and 15 milligrams against placebo. And as you can see with the highest dose, you're getting about 22%. So not only are we in double digit, but we're over 20%. And if we look at the categorical weight loss with these agents, we can see that at least a third of patients lose 25%. Okay, so this is pretty good. Now, what we also, one thing to say, everybody is worried about muscle or lean muscle loss with these agents because the weight is so significant. And just to highlight some of the post-hoc analysis from the SURMOUNT trial, which has looked at the percentage change in fat mass, as you can see, compared to the lean mass. And what you can see here, these are the 3 different ages, less than 50, 50 to 65, and the over 65. This is the percentage change in fat mass, and this is the percentage change in lean mass. And you can see a 3-to-1 ratio across all ages, actually. So it's quite reassuring that even the elderly, are not losing. That the ratio is much the same, so like in a 3-to-1 ratio. Okay, so there is a reduction in lean mass, but an overall improvement in body composition. But it's really important that these patients are followed up and that they do have, they do physical activity and they eat enough protein to make sure that they don't run into trouble. Okay, and we've seen this, so the point is if we stop the medication, weight is regained. Obesity is a chronic disease. We wouldn't stop a blood pressure tablet, we wouldn't stop a statin. It's the same concept, okay? So this is just where you are about a year after stopping the medication. You're about 5% from baseline with semaglutide. And we've seen this slide a million times today again with SURMOUNT-4, where everybody was on tirzepatide, and then at 36 weeks those that stopped and went on to placebo regained weight. So about 10% from baseline. If you continue, you're about 25% mean weight loss at 88 weeks. Okay. So, but it's not about the weight loss. Okay, it's really about improving health and cardiovascular outcomes. And again, you've seen some of these slides today, so hopefully this should be just revision. And the SELECT trial is very important. I know we keep banging on about this, but this is a landmark trial. These are patients without diabetes, 17,000 patients that were who had an MI or a stroke, essentially randomized to semaglutide 2.4 or placebo, and the results showed a 20% risk reduction in a further cardiovascular event. So we should be actually asking ourselves why are we not starting everybody with a BMI over 27, age 45 and above, one of these medications. Now, this was also shown by Alex this morning. As you can see, heart failure. So if you take heart failure again, these are the patients' views. So this is data again with semaglutide. There's only about 30% weight loss reduction, but an improvement in this Kansas City cardiomyopathy questionnaire. The higher the score, the better the physical activity. And you can see that this is again the first time that we've seen this, and indeed the same data has just been released for tirzepatide. Okay, so improvements in heart failure. Okay. What about kidney disease? Again, these are data with semaglutide 1 milligram, not the 2.4 milligram, because these were patients with type 2 diabetes. So these patients had kidney disease, and the introduction of semaglutide essentially reduced the risk of kidney disease progression and kidney and cardiovascular death by 24%. You can see here the reduction in EGFR is much slower with semaglutide compared to placebo. These drugs are beneficial. It's not just SGLT2s. So when we're talking about stopping SGLT2s and perhaps GLP-1s after bariatric surgery because patients get better, perhaps we need to think about actually, are we doing harm, because these meds actually improve cardiovascular risk. You've seen the results of the obstructive sleep apnea with tirzepatide. Again, very nice weight loss with tirzepatide, and a significant reduction in the apnea-hypopnea index. These were patients with moderate to severe obstructive sleep apnea. 2 trials were done, well, the same, half were on CPAP, half were not, but essentially by using the medication, at least 50% of patients can actually get to a stage where they can come off their CPAP machine. So all good stuff. And the final thing I'm going to show you in terms of complications, because I can show you loads and you've seen already the liver stuff, is the step 9 data, which was recently published, again, using this questionnaire called the WOMAC pain score. This is the weight loss, and on sort of body weight, as you can see here, and a significant reduction in this pain score patients with semaglutide, i.e. improvements in osteoarthritis. So perhaps we're going to be using this in these patients as well. Okay, so that's where we are now, but what is the future of obesity pharmacotherapy, okay, which is actually what I'm supposed to be talking about. And a lot of it is really based on what we call nutrient-stimulated hormones, or NASH-based therapies, and they're all based on these incretin hormones that we're familiar with. So we are all familiar with the GLP-1 agonists and the combination of GLP-1 and GIP, which is tirzepatide, of course, but there's a number of combinations: glucagon, amylin. Amylin is cagrilintide in its analog form, and PYY. And this is all very exciting. And I will show you some of the sort of data showing us the sort of weight loss that we can get with these new agents. There's also a new class of agents which have nothing to do with incretin therapies, called the myostatin activin pathway inhibitors. And I will mention these because this class of drugs actually improves lean muscle mass whilst achieving fat mass loss. And I think this is important, and in the future we may be using the combination of these agents together with the incretin therapies sort of to protect the lean muscle mass loss. So this is just a snapshot of some of the medications that are currently in clinical trials. So semaglutide and tirzepatide you know about. We are currently coming up to the end of the combination of cagrilintide, which is amylin, and semaglutide in phase 3, and those results will hopefully be available soon. You can see lots of combinations, glucagon and GLP-1 receptor agonists. You've seen the data for semaglutide. I can't pronounce half of these. Really exciting, the triple G, so that's the GLP-1, GIP, and receptor agonists, showing really good results in phase 1 and the phase 2, which I'll show you about. And then some of the oral agents. We've heard about oral semaglutide, although I think up to 40 milligrams. The dose is 50 milligrams for in terms of the weight loss dose, although it is quite expensive and I think availability will be an issue at that dose. But there are some other probably more exciting because they're even sort of manufactured more easily, and I'll show you some of the orthoglobal data quite quickly. There's also monthly combination therapies as well that are currently being developed. So it's a very rich field of development. But let me just show you a couple of these. So orforglipron is an oral medication, okay? It is a non-peptide GLP-1 agonist. Why is that important? It's important because the drugs that we have thus far are peptide, they're difficult to manufacture, that's why it's so difficult to scale them up globally, and that's why we've had shortages, okay? This stuff is a non-peptide. Hopefully it comes through and you can see the weight loss is about 15%, which is similar to what we're getting with injectable semaglutide at 2.4. This does not need to be taken half an hour before breakfast. You can take it whenever you like. The bioavailability is much greater than the oral semaglutide that we've just heard about. Okay, so I think this is important and hopefully cheaper than and more available globally. Okay, so this is just to show the results of the phase 1 trial of the combination of cagrilintide, that's amylin and semaglutide. So here's the combination of the two at 2.4 milligrams at 20 weeks, 17% weight loss. We're very excited to see the results of the phase 3 clinical trials to see what sort of weight loss we're going to get with the combination of this. Now, the triple hormone is really, I think, is very exciting. Here's again phase 2 clinical. Phase 2 means you're looking at different doses, but at the highest dose of this, a mean weight loss of 24%, as you can see here, and over, I think, a quarter of patients achieving over 30% weight loss. So we're truly in bariatric territory. And the other exciting thing about this, I'm not sure if I've got the slide. I do have the slides. Yes. Women do a lot better. So actually in that particular trial, 50% were women, usually there's many more women in these trials, but the women lost about 28% compared to the men only losing about 22%. Okay, so there's something about the estrogen, I don't know what it is, that makes women lose more weight. And indeed that's the same actually with drugs such as tirzepatide and semaglutide. You might not have realised that because most trials are actually in women, but you know, women do actually do better. Right. Just a quick word about the myostatin activin pathway inhibitors. What are these? Well, essentially, myostatin and activin A are involved in the cancer pathways. You know, patients with cancer, they have muscle wasting and cachexia. If we can therefore inhibit these pathways, okay, we might be able to basically reverse this cycle of muscle wasting and cachexia. And that's exactly what these medications are trying to do. So that's the sort of principle behind these medications. One of these is called bimagrumab. I don't know whether you've heard of bimagrumab, but essentially it's an antibody that blocks this activin type 2 receptor. It's been injected monthly for 48 weeks in patients, and you can see that the preliminary results show a 20% reduction in the fat mass, but an increase of 3.6% in muscle mass. Okay, so we look forward to seeing some of these agents coming through, and there's a whole host of these. This is some of their names. What I'm trying to, I guess, project here is that there is quite an exciting sort of pipeline of future medication coming through. Okay, now are they safe? You know, patients will ask you, you know, if I need to take this medication for the rest of my life, you know, am I going to be a cancer doctor? I think the answer is probably yes, at least at this point in time. This is just to show you some of the data from the US data comparing the uses of semaglutide or liraglutide compared to compliant naltrexone. And we can see here that there was no difference in increase in biliary disease, but 9 times more likely to get pancreatitis, 4 times more likely to get bowel obstruction, and 3.5 times more likely to get gastroparesis. These are side effects that we are familiar with. The pancreatitis, I mean, we know that if you lose weight very quickly, whether it's through lifestyle, through medication, through bariatric surgery, you guys give us deoxycholic acid for 6 months, you know, to prevent gallstones and pancreatitis. Okay, so we're not aware of a direct GLP-1 effect on the pancreas. Okay, so we think it's likely to be due to gallstone disease, and so we need to warn patients about this. What about cancer? Well, firstly, we know that if we reduce weight, our sort of risk of cancer is much reduced. Now, I'm going to quote you just this sort of systematic review meta-analysis, 37 study, 46,000 patients. which showed no increase in pancreatic cancer, no increase in thyroid cancer, and indeed no increase in any neoplastic activity. And I think there was another journal paper very recently that pretty much supports this data. I should say that there was another meta-analysis that showed specifically to thyroid cancer that it was no different, but there was a report actually, I think in 2023, a French study that did suggest that there was an increased risk of thyroid cancer. And again, I think if you look at how some of the statistics were done, it might reflect a detection bias rather than a sort of a true increased risk. So there's still a little bit of debate out there, but really, I think on balance, the benefits from these medications by far outweigh the risk of any cancer, and we know that, like I said, the overall prevalence is reduced. What about risk of suicide? Again, lots of talk about this, and I could go on and on, but essentially there is no risk of increased suicide. This is just the data. For instance, we published a post-op analysis of all the step 1, 2, 3, and 5 trials at the start of this. And again, semaglutide did not increase the risk of depression, suicidal ideation, and so on and so forth. And at this point in time, there is absolutely no data to suggest that they increase risk. The limitation is, of course, that in these trials, patients with severe mental health disease were excluded. So we just have to bear that in mind. Okay, so finishing off really, supply, demand, cost, and inequalities. Now, we know there's been a huge demand for these drugs. These are data from the States, where essentially 1 in 8 patients has had a GLP-1 of sorts, and there's been a 2,000% increase in the medication since the launch of semaglutide. Does anybody know how many prescriptions we have here in the UK? I think, or England? Any idea? Well, in the NHS too, yes. But actually, so there's actually about 400,000 people, nearly 500,000 people actually taking these meds, okay? In the NHS, only about 700 prescriptions, okay? So this is all private, okay? So people are actually, it's about 400,000, it's a lot of people, okay? Now that we have a bit of recovery, we've all, of course, we've had a nightmare, especially patients with diabetes running out, because we were all using them off license, at least privately, to manage the weight. But at the moment, there is a supply, at least, of both semaglutide and the Mounjaro. But just a reminder about what is actually happening on the shop floor. So these drugs are licensed at a BMI of 30 or a BMI of 27 plus 1 complication. That's the licensing, okay? What does NICE say? So for semaglutide, NICE says BMI of 35 plus at least 1 complication, okay? You've got to stop if you lose 5% in 6 months, and maximum treatment duration is 2 years, which is completely ridiculous. Yeah. And we've, no clinician agrees with this particular concept, because why would you stop medication for a chronic disease? But anyway, that's what NICE says. According to NICE, we've got, 4 million people, something 4 to 6 million people in the UK eligible. Like I said, we've really given it to 700. What we try to do is basically try and prioritise who gets semaglutide. This is what we're doing locally. We basically got together with the SFP and the Obesity Management Collaborative to come up with some guidelines. We're now giving it to those with active malignancy who need to lose weight loss rapidly, radiotherapy surgery. For those patients who need a kidney or a heart transplant and need to lose weight. For those with raised intracranial depression requiring lumbar punctures to relieve their pain or to protect their eyesight, and so on and so forth. You can see, and also for those with severe sleep apnea, and you can argue for and against some of these, but that's where we are. And the second phase will probably line up with what tirzepatide will come up with, which I think is a BMI of 40 plus sort of 3 random indications that NICE has plucked up of the air. Except these are a BMI of 35, whereas the new ones will be a BMI of 40 plus 3 complications, unless NICE listens to all the feedback that we've given them, because they would actually miss out all of these tirzepatide, if you think about it, because if you have active malignancy, if you waited for an organ transplant, none of those might have a BMI of 40 with 3 complications. So anyway, we'll see. But what we want to do is align the 2 medications. We don't want to have one pathway for tirzepatide, one pathway for Mounjaro. It just doesn't make any sense. Okay. But really what we have is a highly prevalent disease, huge patient suffering, what is development of second generation medications which are effective but expensive, and most patients are basically not getting any access, and it's a real problem, and we need to try and solve this together. Before I finish up, I just wanted to have a quick word about digital therapies. I think it is really important to follow patients on these medications for all the reasons that we've discussed, because of the side effects, because you need to titrate slowly, because they do lose muscle mass, because they need nutritional advice, which is a different type of advice. It's not about reducing calories, because the medication does that for you, but it's about ensuring that patients eat enough protein and enough nutrients to stay healthy. And we've learned a lot from the COVID pandemic about digital services and how we can reach patients at home, how we can scale up quickly, because unfortunately 50% of the country does not have any obesity services, but also because 99% of obesity actually is in primary care. Okay, so we need to help our primary care physicians to manage this disease. There are now, I think, 7 NICE approved digital weight management services. I'm actually involved in one of them called Roxanne. This is the data that in terms of lifestyle loss without the drug that we achieved at 1 year, so about sort of 8%. This is a multidisciplinary medical obesity service which is offered digitally to patients, and the Roxanne Plus will be with the medication. But what I'm saying is we need to try and reach out to digital in our services to help, because we cannot just don't have the resources, I think, to scale up to the demand that is out there. Okay, so conclusions. I think current medical therapies for obesity have bridged the gap between lifestyle and bariatric surgery, and the new dual and triple gut hormone therapies are showing promising results. But I do think that we have these inequalities in obesity care, lack of access, lack of funding, which are likely to continue for many, many years. And I hope that the introduction of oral, more affordable pharmacotherapy may be able to reduce this